Good morning, everyone. Today we will discuss respiratory pandemics, specifically three major respiratory diseases that have significantly affected global health: severe acute respiratory syndrome, or SARS, avian flu, COVID-19. As future nurses, it is important not only to know their causes, but also how they spread, their clinical manifestations, diagnosis, management, and the nursing responsibilities in caring for affected patients. Let's begin with SARS. Severe acute respiratory syndrome, SARS. SARS is a life-threatening viral respiratory illness caused by the SARS-associated coronavirus, also known as SARS-CoV. It was first identified in Guangdong Province, southern China in 2003, and within a short period it spread rapidly to several countries through international travel. Patients usually present with flu-like symptoms such as fever, cough, and body aches. However, unlike ordinary influenza, SARS can rapidly progress to pneumonia, respiratory failure, and even death if it is not recognized and treated promptly. At the height of the outbreak, the World Health Organization, or WHO, played a major role in controlling the spread of the disease. Together with the Global Outbreak Alert and Response Network, WHO coordinated investigations, assisted affected countries, and provided epidemiological, clinical, and logistical support. Through international collaboration, strict surveillance, isolation, and infection control measures, the outbreak was eventually brought under control. Today, the virus responsible for that outbreak is referred to as SARS-CoV-1. The number 1 was added later to distinguish it from SARS-CoV-2, the virus responsible for COVID-19. The SARS outbreak also taught the global healthcare community valuable lessons. It highlighted the importance of early disease detection, rapid reporting, strict isolation precautions, proper use of personal protective equipment, and international cooperation in preventing future pandemics. Now let's discuss how SARS spreads from one person to another. Understanding its mode of transmission is essential because it helps us implement the appropriate infection control measures. The primary mode of transmission is through respiratory droplets. When an infected person coughs or sneezes, tiny droplets containing the virus are expelled into the air. These droplets usually travel only a short distance, about 3 feet or 1 meter, before landing on the mucous membranes of another person's eyes, nose, or mouth, where the virus can enter the body. This is why wearing a mask and maintaining physical distance are effective preventive measures. The second mode is close person-to-person contact. This includes activities such as kissing, hugging, or touching an infected individual. Transmission can also occur indirectly when a person touches surfaces or objects contaminated with infectious droplets and then touches their own eyes, nose, or mouth without first washing their hands. This highlights the importance of frequent hand hygiene and environmental disinfection in preventing the spread of infection. Lastly, although less common, oral fecal transmission has also been reported. In this route, the virus may spread through contamination of sewage or water systems. This emphasizes the need for proper sanitation, safe waste disposal, and access to clean water, especially during outbreaks. Now let's understand the pathophysiology of SARS, or what happens inside the body after infection. It begins when the virus enters the body through the nose, mouth, or eyes after exposure to infected respiratory droplets or contaminated surfaces. The virus travels to the respiratory tract, infects the alveolar epithelial cells in the lungs, and begins to multiply. The body's immune system responds by releasing cytokines and neutrophil chemokines to fight the infection. However, in severe cases, this response becomes excessive, leading to a cytokine storm where too many inflammatory substances are released, causing damage to healthy lung tissue. As inflammation worsens, the alveoli, or tiny air sacs in the lungs, become damaged. Fibrin, macrophages, and inflammatory cells accumulate, causing the alveoli to fill with fluid and debris instead of air. This results in impaired gas exchange, leading to hypoxemia, worsening shortness of breath, and viral pneumonia. If the inflammation continues, the patient may develop acute respiratory distress syndrome, or ARDS, which can progress to respiratory failure, multi-organ dysfunction, and even death if not treated promptly. Let's move on to the clinical manifestations of SARS. One important characteristic of SARS is that infected individuals become contagious only after symptoms begin, unlike some respiratory viruses that can spread before symptoms appear. The risk of transmission is highest during the second week of illness, when the viral load is greatest. The incubation period is usually 2 to 7 days after exposure, although some cases may take slightly longer. The first symptom is typically a high fever of more than 38 degrees Celsius, followed by a dry cough and difficulty breathing, which are considered the hallmark manifestations of SARS. As the illness progresses, patients commonly experience headache, fatigue, muscle aches, and a general feeling of malaise or discomfort. Some individuals may also develop diarrhea, indicating that the infection can affect systems beyond the respiratory tract. By approximately 7 to 10 days after symptom onset, many patients develop viral pneumonia, which can be seen on a chest X-ray. At this stage, respiratory symptoms often worsen, and some patients may progress to acute respiratory failure, requiring oxygen therapy or mechanical ventilation. As nurses, it is important to recognize these warning signs early. A patient with persistent high fever, worsening cough, increasing shortness of breath, and radiographic evidence of pneumonia requires immediate assessment and close monitoring because these findings may indicate progression to severe disease. In summary, the key clinical manifestations of SARS include high fever, cough, dyspnea, headache, fatigue, muscle aches, diarrhea, and eventually pneumonia, with the greatest risk of transmission occurring during the second week of illness. Let's discuss the diagnostic tests used for SARS. Because the symptoms of SARS resemble those of many respiratory infections, several laboratory and imaging tests are performed to confirm the diagnosis, identify other possible causes, and assess disease severity. The number one diagnostic test is the real-time reverse transcription polymerase chain reaction, or RT-PCR assay. It detects the genetic material, or RNA, of the SARS coronavirus and is considered the gold standard for confirming SARS infection. Another important laboratory finding is the white blood cell count, or WBC. Many patients with SARS have a normal or decreased WBC count, particularly lymphopenia, which can help support the diagnosis and monitor disease progression. A chest X-ray is performed to detect pneumonia, which commonly develops as the disease progresses. Blood cultures and sputum culture with sensitivity testing are obtained to identify or rule out secondary bacterial infections. Patients are also tested for other respiratory viruses, including influenza A, influenza B, and respiratory syncytial virus, or RSV, since these infections can present with symptoms similar to SARS. A urinary antigen test may also be requested to detect bacterial causes of pneumonia, particularly Legionella and Streptococcus pneumonia. Finally, an arterial blood gas, or ABG, is performed to evaluate the patient's oxygenation and acid-base balance. This is especially important in patients with respiratory distress because it helps determine the severity of impaired gas exchange and the need for oxygen therapy or mechanical ventilation. In summary, the key diagnostic tests include RT-PCR as the gold standard, WBC count, chest X-ray, blood and sputum cultures, viral testing, urinary antigen testing, and ABG analysis to confirm the diagnosis and guide treatment. For the medical management of SARS, at present there is no specific cure for SARS. Therefore, treatment is mainly supportive and focuses on relieving symptoms, maintaining adequate oxygenation, and preventing complications. The first priority is strict isolation to prevent transmission, together with symptomatic management such as providing oxygen, maintaining hydration, controlling fever, and monitoring the patient's respiratory status. Although no antiviral drug has been proven to be completely effective, medications such as ribavirin and the combination of lopinavir-ritonavir have been used in some patients to reduce viral replication. To control the excessive inflammatory response, corticosteroids and intravenous immunoglobulin, or IVIG, may be administered in selected cases. Another treatment option is convalescent plasma therapy, which uses plasma from individuals who have recovered from SARS to provide antibodies that may help fight the infection. If the patient develops a secondary bacterial infection, appropriate antibiotics are prescribed. For patients experiencing respiratory distress, non-invasive positive pressure ventilation such as a face mask may be used to improve oxygenation. However, if respiratory failure progresses, mechanical ventilation becomes necessary to support breathing. One of the most serious complications of SARS is respiratory failure. As the infection progresses, inflammation and fluid accumulate in the alveoli, making it difficult for oxygen to enter the bloodstream. When the lungs can no longer provide enough oxygen or remove carbon dioxide effectively, the patient develops respiratory failure. This is a life-threatening condition that often requires intensive care, mechanical ventilation, and close monitoring. Based on the patient's condition, several nursing diagnoses are commonly identified. The first is ineffective breathing pattern, which is related to lung inflammation and is manifested by rapid labored breathing and shortness of breath. The second is impaired gas exchange due to alveolar damage and fluid accumulation, resulting in hypoxemia and decreased oxygen saturation. The third is ineffective airway clearance because increased respiratory secretions and inflammation make it difficult for the patient to clear the airway effectively. Lastly, altered nutrition may occur because patients often experience fever, fatigue, dyspnea, and poor appetite, leading to decreased nutritional intake and increased metabolic demands. Finally, let's discuss the nursing interventions for patients with SARS. Since SARS is highly contagious, our priority is to prevent transmission while providing supportive respiratory care. The first intervention is strict isolation and infection control. This includes performing proper hand hygiene before and after patient contact, wearing appropriate personal protective equipment such as masks, practicing environmental cleaning and disinfection, and implementing measures to safely contain the patient's respiratory secretions. These practices protect not only the patient but also healthcare workers and other patients. Second, we should monitor the patient's vital signs, particularly the respiratory rate, oxygen saturation, temperature, heart rate, and blood pressure. Frequent assessment allows us to recognize early signs of respiratory deterioration and intervene promptly. Lastly, we promote pulmonary hygiene to keep the airways clear and improve ventilation. This includes encouraging coughing and deep breathing exercises when appropriate, positioning the patient to maximize lung expansion, maintaining adequate hydration to help loosen secretions, and providing oxygen therapy as prescribed. Now that we've discussed severe acute respiratory syndrome or SARS, let's move on to our second respiratory pandemic, which is avian influenza, more commonly known as bird flu. Avian influenza or bird flu is an infectious disease caused by the influenza A virus that primarily infects birds and poultry. It affects both wild birds and domesticated birds, including ducks, chickens, and turkeys. The strain most commonly associated with severe human disease is H5N1. The name H5N1 refers to two proteins found on the surface of the virus, hemagglutinin type 5, H5, and neuraminidase type 1, N1. These surface proteins help the virus attach to and infect host cells. Humans usually become infected through close contact with infected or sick poultry, particularly during handling, slaughtering, or preparing birds for consumption. Although human infections are relatively rare, they are often very severe, with a case fatality rate of approximately 60%, making H5N1 one of the deadliest influenza viruses known to infect humans. The first confirmed human case of highly pathogenic avian influenza was reported in Hong Kong in 1997, and since then, most cases have occurred in Southeast Asia and Africa. One major concern is that influenza viruses mutate frequently. Scientists closely monitor these mutations because if the virus acquires the ability to spread efficiently from person to person, it could trigger a regional outbreak or even another global pandemic. Bird flu is transmitted primarily from bird to bird. The virus is present in the saliva, nasal secretions, and droppings of infected birds. When these secretions contaminate the environment, they become a source of infection for other birds. Healthy birds become infected when they come into direct contact with infected birds or indirectly through contaminated surfaces such as cages, feeding equipment, water sources, or farm environments contaminated with infected saliva or feces. Although bird-to-bird transmission is the most common route, humans can also become infected after close exposure to infected poultry or contaminated environments, especially in poultry farms or live bird markets. This is why good farm biosecurity, proper sanitation, and immediate isolation or culling of infected birds are essential measures to prevent the spread of avian influenza. Although bird flu primarily infects birds, humans can become infected through close exposure to infected birds or contaminated environments. Individuals at the highest risk include those who care for sick birds, slaughter or kill infected poultry, and prepare sick birds for consumption. These activities increase exposure to the virus found in the bird's saliva, respiratory secretions, and droppings. Other risk factors include indirect contact with bird feces, handling unwashed eggs from infected birds, and exposure to water contaminated with infected droppings. Although human-to-human transmission is rare, it has been reported, particularly among individuals who provide close and prolonged care to infected patients such as family members and healthcare workers without appropriate personal protective equipment. These risk factors highlight the importance of using proper protective equipment, practicing good hand hygiene, safely handling poultry products, and following infection control precautions to reduce the risk of transmission. The illness usually begins with flu-like symptoms, including fever, cough, sore throat, and myalgia, or muscle aches. These are often the first signs of infection and may resemble seasonal influenza. As the disease progresses, patients may also experience nausea, vomiting, and diarrhea, indicating that the virus can affect not only the respiratory system but also the gastrointestinal tract. Some patients may even develop eye infections such as conjunctivitis. Unlike seasonal flu, however, H5N1 can progress rapidly to severe disease. Within a short period, patients may develop viral pneumonia, which can worsen into acute respiratory distress syndrome, or ARDS, and eventually respiratory failure. Without early recognition and prompt treatment, these complications can be fatal. Let's now discuss the diagnostic tests for avian influenza. The gold standard test is the polymerase chain reaction, or PCR, which detects the genetic material of the influenza A virus, providing a rapid and accurate diagnosis. A nose and throat swab is collected to obtain respiratory specimens for PCR testing or viral culture. In patients who develop pneumonia, a sputum culture may also be performed to identify any secondary bacterial infection that may require antibiotic therapy. Together, these tests confirm the diagnosis and help guide appropriate treatment. Moving on to medical management, the cornerstone of treatment is early antiviral therapy. The recommended antiviral medications are oseltamivir or Tamiflu and zanamivir or Relenza. These drugs work by preventing the virus from multiplying and are most effective when started within 48 hours after symptoms begin. Supportive care, including oxygen therapy, hydration, and treatment of complications, is also essential. Unfortunately, despite treatment, H5N1 infection has a poor prognosis, with approximately 60% mortality, highlighting the importance of early diagnosis and prompt intervention. Since bird flu has a high mortality rate, prevention remains our best defense. People should avoid contact with sick or dead poultry, especially in areas experiencing outbreaks. On poultry farms, preventive measures include vaccinating birds and culling infected flocks to stop the spread of the virus. Proper handling and thorough cooking of poultry and eggs are also important. In addition, regular hand washing, proper cleaning of contaminated surfaces, and wearing masks or other respiratory protection when caring for infected patients help reduce transmission. For individuals with close exposure to a confirmed case, oseltamivir may be given as post-exposure prophylaxis to lower the risk of infection. As nurses, one of our most important responsibilities is health education. We should teach patients to wash their hands with soap and water for at least 20 seconds before and after handling raw poultry or eggs. Kitchen utensils, cutting boards, and food preparation surfaces should be cleaned thoroughly with soap and hot water to prevent cross-contamination. Finally, remind patients to cook poultry thoroughly and cook eggs until the yolk and white are firm, because proper cooking effectively kills the virus. Through patient education and strict infection control practices, we can significantly reduce the spread of avian influenza and protect both individuals and communities. COVID-19 is an infectious respiratory disease caused by a newly discovered coronavirus known as SARS-CoV-2. It was first identified in late 2019 and rapidly spread across the globe, leading the World Health Organization to declare it a global pandemic. Like SARS, COVID-19 primarily affects the respiratory system, but it can also involve many other organs, including the heart, kidneys, brain, and blood vessels. Most people infected with COVID-19 experience mild to moderate symptoms such as fever, cough, sore throat, and fatigue, and recover without the need for special treatment. Supportive care, adequate rest, hydration, and proper nutrition are often sufficient for these patients. However, some individuals, particularly older adults, immunocompromised patients, and those with chronic conditions such as diabetes, hypertension, or heart disease, are at a much higher risk of developing severe illness. These patients may progress to pneumonia, acute respiratory distress syndrome, ARDS, respiratory failure, multi-organ dysfunction, and even death. COVID-19 is transmitted through three main routes. The most common is respiratory droplets. When an infected person coughs, sneezes, talks, or even breathes, droplets containing the virus are released. These droplets can enter another person's eyes, nose, or mouth, leading to infection. The second route is through fomites or contaminated objects and surfaces. A person may become infected after touching a contaminated surface and then touching their eyes, nose, or mouth without first washing their hands. Finally, COVID-19 can also spread through airborne transmission. Tiny infectious particles called aerosols can remain suspended in the air, particularly in enclosed or poorly ventilated spaces. This is why proper ventilation and wearing well-fitting masks are important preventive measures. Clinical manifestations. COVID-19 affects people differently. While most infected individuals develop mild to moderate illness and recover without hospitalization, others may develop severe disease, especially older adults and those with underlying medical conditions. The most common symptoms include fever, dry cough, and fatigue. Other symptoms may include body aches, sore throat, headache, diarrhea, conjunctivitis, and the characteristic loss of taste or smell. Some patients may also develop skin rashes or discoloration of the fingers and toes. To guide appropriate treatment, COVID-19 is classified into 4 levels of severity based on the recommendations of the Philippine Society for Microbiology and Infectious Diseases, or PSMID. The first category is non-severe COVID-19, which includes mild and moderate cases. Mild COVID-19 refers to patients who have no pneumonia and no hypoxia. They usually present with fever and cough, along with symptoms such as sore throat, runny nose, headache, muscle aches, diarrhea, nausea or vomiting, fatigue, and loss of taste or smell. Moderate COVID-19 includes patients with pneumonia but no signs of respiratory distress. Their respiratory rate is less than 30 breaths per minute, and their oxygen saturation is 94% or higher. This category also includes patients without pneumonia but who are at high risk of disease progression, such as older adults or those with chronic illnesses. The second category is severe COVID-19. These patients have pneumonia with respiratory distress, an oxygen saturation below 94%, and a respiratory rate greater than 30 breaths per minute. They usually require supplemental oxygen and close monitoring. The most serious category is critical COVID-19. These patients have impending or established respiratory failure and may require high-flow oxygen, non-invasive ventilation, or mechanical ventilation. They may also develop acute respiratory distress syndrome, ARDS, sepsis, septic shock, altered level of consciousness, or multi-organ failure, all of which require management in the intensive care unit. Now let's understand the pathophysiology of COVID-19, or what happens inside the body after a person becomes infected. The process begins when SARS-CoV-2 enters the body and uses its spike, or S protein, to attach to ACE2 receptors found on the surface of many cells, particularly those in the lungs. The virus also requires the TMPRSS2 enzyme to help it enter the host cell. Once inside, the virus multiplies rapidly. As the virus replicates, it disrupts the normal inflammatory response and increases the effects of angiotensin II, leading to widespread inflammation. The immune system responds by releasing large amounts of pro-inflammatory cytokines such as IL-1, IL-6, and TNF-alpha. In severe cases, this results in a cytokine storm where the immune system becomes overactive and begins damaging healthy tissues instead of protecting them. At the same time, COVID-19 also affects the blood clotting system by reducing fibrinolysis and promoting clot formation. This creates a state of hypercoagulability, increasing the risk of microthrombi and larger blood clots. Inside the lungs, inflammation increases the permeability of the lung capillaries, allowing fluid to leak into the alveoli. As a result, gas exchange becomes impaired, causing hypoxemia, diffuse ground glass infiltrates on imaging, and eventually acute respiratory distress syndrome, or ARDS, which is one of the leading causes of death in severe COVID-19. Because ACE2 receptors are also present in other organs, the virus can affect the heart, causing myocardial injury and cardiogenic shock, and the kidneys, leading to acute kidney injury with proteinuria and hematuria. In summary, the sequence is straightforward. SARS-CoV-2 binds to ACE2 with the help of TMPRSS2, enters the cells, triggers excessive inflammation and abnormal clotting, causing hyperinflammation and hypercoagulability. If severe, this progresses to ARDS and eventually multi-organ dysfunction syndrome, or MODS, affecting the lungs, heart, kidneys, and other organs. The gold standard for diagnosing COVID-19 is the SARS-CoV-2 real-time reverse transcription polymerase chain reaction, or RT-PCR, performed using a nasopharyngeal swab. This test detects the viral RNA and remains the diagnostic test of choice for confirming COVID-19 infection. For patients with severe illness, several laboratory markers help assess the degree of inflammation and organ involvement. These include elevated D-dimer IL-6C reactive protein, or CRP, procalcitonin, troponin, LDH, and ferritin. These markers are associated with severe disease and poorer outcomes. An arterial blood gas, or ABG, is also performed to evaluate oxygenation and determine the severity of respiratory failure. In terms of imaging, a chest X-ray is recommended for patients with moderate to severe COVID-19, those at high risk for progression, or patients with symptoms lasting 5 days or more. It helps detect pneumonia and guides clinical management. A chest CT scan provides a more detailed assessment of lung involvement and is particularly useful in suspected cases requiring rapid evaluation or when RT-PCR is unavailable or delayed. The most common serious complication of COVID-19 is acute hypoxemic respiratory failure. This occurs because inflammation and fluid accumulation in the alveoli impair gas exchange, resulting in severe hypoxemia. Without prompt treatment, patients may progress to acute respiratory distress syndrome, ARDS, and require advanced respiratory support. Let's discuss when a patient with COVID-19 should be admitted to the intensive care unit, or ICU. Patients require ICU admission when they show signs of critical illness and need advanced monitoring and life support. The admission criteria include: first, patients who require 6 to 8 liters of oxygen per minute or more, just to maintain an oxygen saturation of at least 90 to 92%. Second, patients who develop respiratory failure, meaning they can no longer maintain adequate oxygenation or ventilation on their own. Third, patients who are in shock, where blood pressure drops and vital organs do not receive enough blood flow. Fourth, patients with acute organ dysfunction, such as acute kidney injury, myocardial injury, or altered mental status. And finally, patients who are at high risk for rapid clinical deterioration, even if they have not yet developed respiratory failure, should also be closely monitored in the ICU. As nurses, recognizing these ICU admission criteria is essential because early transfer to critical care allows timely interventions that can improve patient outcomes and reduce mortality. Now let's discuss the critical care and respiratory management of patients with COVID-19. Management depends on the severity of the disease. For patients with mild COVID-19, treatment is mainly supportive care. This includes antipyretics for fever, adequate oral hydration, home isolation or temporary treatment facilities, and close monitoring for worsening symptoms. For hospitalized patients with severe COVID-19, several evidence-based treatments are available. The first is antiviral therapy. Remdesivir is recommended for eligible hospitalized patients and is most effective when started within 7 days of symptom onset. Other oral antivirals include Paxlovid, which contains nirmatrelvir and ritonavir, and molnupiravir for selected patients with mild to moderate disease who are at high risk for progression. To reduce the excessive inflammatory response, immunomodulators such as tocilizumab and baricitinib may be administered. These drugs help suppress the cytokine storm and reduce the need for mechanical ventilation. Patients requiring supplemental oxygen should receive corticosteroids such as dexamethasone or methylprednisolone, which have been shown to reduce mortality in severe COVID-19. Because COVID-19 increases the risk of blood clots, prophylactic anticoagulation is recommended for hospitalized patients unless contraindicated. If a patient develops hemodynamic instability or shock, norepinephrine is the first-line vasopressor, while vasopressin may be added in selected patients. Dobutamine may also be used for patients with acute heart failure. Loop diuretics, oral or intravenous, for fluid overload and active management of hyperkalemia and metabolic acidosis with potassium binders and sodium bicarbonate. For patients without indication of RRT. For patients with ARDS, conservative fluid management is preferred to avoid worsening pulmonary edema. To improve oxygenation, nurses should anticipate interventions such as prone positioning, high-flow nasal cannula oxygen therapy, and, when necessary, lung protective mechanical ventilation using low tidal volumes and appropriate PEEP to minimize ventilator-induced lung injury. For patients with refractory hypoxemia who do not respond to conventional treatment, advanced therapies such as extracorporeal membrane oxygenation or ECMO may be used. If acute kidney injury develops, continuous renal replacement therapy, CRRT, or sustained low-efficiency dialysis, SLED, may be required. Finally, some critically ill patients may undergo hemoperfusion, a therapy that helps remove inflammatory cytokines and other harmful substances from the bloodstream, reducing the severity of the inflammatory response. COVID-19 vaccines help prevent symptomatic infection and, more importantly, reduce the risk of severe illness, hospitalization, and death. They also help reduce transmission within the community. Several COVID-19 vaccines have been approved for use, including Pfizer-BioNTech, given as 2 doses 21 days apart. Moderna, administered as 2 doses 28 days apart. AstraZeneca, given as 2 doses at least 12 weeks apart. Sputnik 5 GamCovidVac, administered as 2 different doses 21 days apart. Janssen Johnson & Johnson, which is given as a single-dose vaccine. And Coronavac, Sinovac, an inactivated virus vaccine administered as 2 doses given 28 days apart. It has been widely used in many countries, including the Philippines, and has been shown to be effective in reducing severe COVID-19 hospitalization and death. Although these vaccines use different technologies, they all work by stimulating the immune system to recognize and fight SARS-CoV-2, thereby protecting individuals from severe disease and its complications. Common nursing diagnoses for patients with COVID-19 includes: the first is ineffective airway clearance, which is related to increased respiratory secretions and inflammation, making it difficult for the patient to maintain a clear airway. The second is ineffective breathing pattern related to shortness of breath. Patients with COVID-19 often experience rapid or labored breathing due to lung involvement and decreased lung compliance. The third is impaired gas exchange, resulting from inflammation and fluid accumulation in the alveoli, which reduces oxygen exchange and may lead to hypoxemia. Finally, patients may experience anxiety associated with the unknown etiology and uncertainty of the disease. Fear of worsening symptoms, isolation, hospitalization, and concern for family members can significantly affect their emotional well-being. Assessment of a patient with suspected or confirmed COVID-19. As nurses, we follow the ABCDE approach to rapidly identify life-threatening conditions and prioritize care. A stands for airway. We assess whether the airway is patent by checking for difficulty breathing, abnormal breath sounds, cough, and sputum production. B stands for breathing. We assess the patient's respiratory rate, work of breathing, oxygen saturation, cough, and lung sounds. Oxygen saturation should ideally be 96% or higher in patients without chronic lung disease. Any signs of respiratory distress require immediate attention. C stands for circulation. We check the patient's heart rate, blood pressure, capillary refill time, and skin color. We also assess for cyanosis and signs of shock such as hypotension and tachycardia. D stands for disability. We evaluate the patient's level of consciousness using the AVPU scale, assess pupillary responses, obtain a history of comorbidities, medications, and symptoms, and check the blood glucose level. Finally, E stands for exposure. We perform a complete physical assessment while maintaining the patient's privacy and following appropriate infection control precautions. Nursing care of critically ill COVID-19 patients. Patients with critical COVID-19 require continuous monitoring and intensive nursing care. First, we closely monitor the patient's airway patency, oxygen saturation, vital signs, level of consciousness, ECG, acid-base balance, coagulation profile, renal and liver function, and signs of deep vein thrombosis or pressure injuries. Second, position the patient in a semi-Fowler's position and reposition every 2 hours to improve lung expansion and prevent pressure ulcers. Third, administer oxygen therapy using a nasal cannula or face mask. If oxygenation remains inadequate, the patient may require high-flow nasal oxygen, non-invasive ventilation, or mechanical ventilation. Adequate nutrition is also important. Early enteral feeding through a nasogastric tube is preferred, while parenteral nutrition may be considered when enteral feeding is not possible. For patients requiring intubation, nurses assist with endotracheal intubation while observing strict airborne and contact precautions to reduce aerosol exposure. Patients on mechanical ventilation require a closed suction system and a dedicated ventilator circuit. We should also implement evidence-based prevention bundles, including the ventilator-associated pneumonia, VAP bundle, catheter-associated urinary tract infection, SAUTI bundle, central line-associated bloodstream infection, CLABSI bundle, and deep vein thrombosis, DVT prevention bundle. Routine nursing care includes oral care with chlorhexidine every 6 hours, central line dressing changes, daily eye care, urinary catheter care, back care, and bed bathing to reduce the risk of hospital-acquired infections. Lastly, we monitor the patient's intake and output, administer prophylactic anticoagulants and intermittent pneumatic compression devices when indicated, and provide fluid resuscitation as needed, aiming to maintain adequate tissue perfusion with a mean arterial pressure, or MAP, greater than 65 mmHg.